Good evening, everyone. Thank you so much for being here tonight. So nice to see so many familiar faces in the audience, and such a glamorous audience as well, I have to say. Everyone's so beautifully turned out tonight. Thank you for being here for another Beauty Triangle discussion. For those of you who have not yet met, I'm Francesca Oakham-White, and I'm the founder of the Beauty Triangle. So we're here tonight to discuss seasonal shifts because finally the clocks have gone forward, summer is glimmering on the horizon, and I think all of us naturally are now thinking about ways to optimise our well-being for the months ahead and certainly into the summer, whether that's preparing our skin for the sun, whether it's finding the latest body therapies to get us beach body ready, or whether it's just the simple sort of at-home hacks we can sort of make for our nutrition to get us energised for those months ahead. Now, when we set up the Beauty Triangle, which was a few years ago now, it was originally with the aim to educate and empower our audiences on all aspects of their health and well-being, but it was also to connect them with the most expert, authoritative voices in the world of wellness. So on that note, it gives me great pleasure to introduce our amazing panel for this evening, starting with Dr. Christine Hall, who is an amazing aesthetic doctor working at the Tech 2 Clinic, the UK's most sought after vein surgeon. If you have any vein issues, Professor Mark Whiteley is your man. And finally, Olga Hamilton, who is an acclaimed nutritionist and TED speaker as well. So this is going to be such an easy talk for you in comparison to doing a TED talk. And they're really here to help us navigate the next few months as summer approaches. Whether that's looking at treatments that are going to work as the summer months hit, whether it's the importance of forward planning, or whether really it's just making those sort of simple, easy to do sort of everyday changes that are going to keep us feeling like our best selves. You may have noticed if you're particularly beady-eyed, but we sadly won't be joined, you'll see it in your programme, by Dr. Suha Kersh, who sadly fell unwell this morning. So at the 11th hour, the wonderful Dr. Christine has stepped in, so I'm immensely grateful to her, and it means that we have a triangle and not just two people and me, so that's really exciting. But we will be doing the Instagram Live with Dr. Kersh at some point very soon, so if you'd like to hear all of her tips and tricks, then by all means, please join that. Just a few things before we do get started. You'll have found your programmes and probably your referral cards on your seat, so you can just leave your name and email address, tick the box, or sort of write the person's name if you'd like us to connect you with any of the speakers that you hear talk here tonight. We'll have a Q&A at the very end, so please hang on to any burning questions right until the end and we will answer those. And we also have an amazing goodie bag for everyone tonight as well. We've got some really gorgeous things from Ground Wellbeing, which is a beautiful spa brand, and from Eela as well, which is one of their sort of skincare brands here at the Lanesborough Spa. So please don't leave that behind either. Enough from me. I'm going to hand over to all of our speakers. They're really quickly going to say a hello and introduce themselves, and then we're going to get started with the main chat. So maybe Christine, you'd like to just...
So good evening, everyone. I'm Christine. As Francesca said, I'm one of the doctors that works at Tech 2 Clinic. By background, I'm a GP, but I was also a pharmacist before that as well.
I'm Mark Whiteley. I'm a consultant venous surgeon, trying to pull venous away from arterial, so vascular is the sort of thing of the past, and I'll be talking a lot about veins, I think.
I think so.
Good evening, everyone. I'm Olga Hamilton. I'm a nutritionist, and I'm in my 10th year of practice currently. I have a clinic in Harley Street, but I also work here at the Lanesborough Club and Spa. They're in-house nutritionists as well. So lovely to have you all here.
Thank you, ladies and gentlemen. So yeah, we're going to start with the main conversation, and Dr. Christine, you're obviously first up. Tell us, Christine, so as the seasons shift, and I think one of the first things that often we notice is in our skin, we notice changes such as texture, pigmentation, oiliness. What are the first things that we can do as consumers to really get to grip with those changes?
Okay, so I think one of the most important things to do is go back to basics. We need to be identifying exactly what these skin changes are. And if you can't do that yourself, one of the best things you can do is get the consultation with an aesthetics doctor or an aesthetics practitioner. And you need to find a practitioner that you get on with, and you need someone that gets you.
So
as well.
important. I always say this to everyone, you've got to find your perfect match with a cosmetic doctor.
You do, because they need to understand what you want and what it is that you're trying to achieve, and then they need to be honest with you and tell you whether or not that's a realistic thing that you're going to get. And once you've done that, I think you need to sit down together, and you need, as I say, you need to go right back to basics. So find out who you are as a person. What's your ethnic background? What are you more prone to developing in terms of skin complaints and skin problems? what's going on in your life at that time. Are you pregnant, for example? Are you taking hormonal contraception or other hormonal medications? Those can affect all sorts of things like pigmentation and things like that.
So there's a lot of deep diving that you need to do, a lot of investigations actually.
Quite a lot. And then things like what do you do? What do you do for a living? Are you spending your time outside working? Are you doing other things? That gives us a really good idea of who you are, what you want, and what you want from us. Okay, so there is no point in me designing a bespoke treatment plan that's going to take you 20 minutes every day to put on your skincare, and it's going to cost this amount of money if that's not something that you want. And
or the person that you are, and if you can't even stick to that every night.
Exactly. So we need to know what you want, what your budget is, how long you want to spend on your skincare, what your ultimate goals and outcomes are. I think once we've established that, we then go to the next level and we think about what are you doing already?
Yeah.
What skincare products are you using? Are you using the right products? And if you are you using them in the right way? So take retinols, for example. We all know that they are amazing ingredients.
The holy grail of skincare.
Exactly. Lots of evidence.
I'm so sad I can't use it right now.
It won't be long.
Yeah.
But if you use them in the wrong way, they can give you problems. So
particularly coming up to the summer as well, when we're going to have sort of so
Exactly.
much more sun exposure, and then you need to be careful about what you then apply on top of the retinol.
Exactly. Layering products in the wrong way, not using SPF when you should be, all those things can actually contribute to things like pigmentation, oiliness and things like that. And it's amazing what you uncover by just sitting down with somebody for half an hour and just making little tweaks.
And unpicking that.
Exactly.
So when it does come to skincare, what are the things that we should be sort of slotting into our regimes for summer? What are the things that maybe we ought to be dropping and sort of leaving in the bathroom cupboard for a few months?
Yeah, okay. So in winter our skin becomes a lot drier. And we all switch to using these heavier moisturisers, things that are more oil-based.
Really sort of lock the moisture in.
Exactly. More occlusive type products, I would say. As we move into the summer, we don't need things that are so heavy. So we need to move away from the kind of oil-based products, move towards more water-based or gel-based moisturisers if you need them. We need to think about incorporating vitamin C's if we're not already. Now, vitamin C is something that I usually recommend that people use all year round.
Because it's so nice for brightening.
Brightening, yeah, it helps with pigmentation. It's an amazing antioxidant all around. But even with vitamin C, so for myself, I really like the SkinCeuticals range of vitamin C's.
Yeah.
They
They're
have
amazing,
4.
like the CE Ferulic and ones like that.
Exactly, yeah. So they have 4. So they have one that's for people with sensitive skin, CE Ferulic, as you mentioned, which is for older, drier skin types, Floritin CF for pigmented skin, and then one that's for oily or acne-prone skin.
Yeah.
Now, for me, I actually have oily and acne-prone skin. So in the summer months and the spring, I use the Silymarin CF.
Yes, exactly. So you're just basically tweaking the skincare based on what your skin needs at that particular time of the year.
Exactly. But in the winter, it's not enough. So I then go to one of the heavier ones, which is something like Floritin CF or even sometimes CE Ferulic. So it's even making those tiny tweaks with the ingredients that we're using.
Any other ingredients we need for the summer? Or is it all about SPF?
A lot of SPF all year round, but particularly in the summer, obviously. And then I think you've got all of the brightening acids, so you've got AHAs and BHAs, so your alpha and beta hydroxy acids. So we're talking about ingredients like glycolic acid, lactic acid. Your BHA is salicylic acid. This is the ingredient that is oil soluble. It's really good for people with acne. Yeah. And all of those are chemical exfoliants, so they help to resurface the skin, and they are the things that give you that really dewy, glowy type of appearance.
And that's nice because then you're not having to use abrasive sort of manual exfoliants to scrub away at the skin. They're just sort of gradually sort of nibbling away at all the dead skin cells. I always think.
Yeah, you're absolutely right, because the ones that contain the abrasive you can see under the microscope that it causes microtrauma.
Yeah, exactly, which is the last thing you need when you've got all these other issues that are bothering you. Your approach is super unique because you blend a lot of your aesthetic knowledge with principles of South Korean skincare as well, don't you? I mean, is that the sort of direction that we're going in aesthetics? Is that beneficial for our skin at this time of year?
So I think we have quite a lot to learn from South Korean skincare and aesthetics.
They're so far ahead of us, aren't they?
They are. So
it's crazy.
Yeah. So I was brought up in a Korean English household. So my mum's South Korean, my dad's English, and anyone that's been to South Korea knows that probably the two most important things are food and skincare.
It's a good combination.
Yeah, but they actually have a really lovely relationship with both. So food they kind of see as a way of showing love, it's a way you respect. There's lots of kind of rituals that surround food, about who gets to eat first and, you know, who, all sorts of things.
Yeah, it's a very respectful culture.
It's very respectful, but skincare is quite similar. Skincare is not seen as a chore in South Korea. It's a kind of ritual and a routine that's passed down through generations. So I distinctly remember being much younger and sitting with my mum and my aunt and my grandma in front of the TV in the evening with a line of skincare products, and we would be tapping them all into our skin and chatting
amazing.
and laughing. And
tapping, is that like a
Tapping.
special sort of technique?
yeah, so they call it tok tok actually.
Really?
Yeah, and the
TikTok.
idea is that it doesn't drag your skin. So instead of all of this pulling, which creates wrinkles, you tok your product into the skin, and it's actually shown to increase absorption and decrease waste.
That's really clever.
So
And also I
it's-
bet it's really nice for the lymphatic drainage if you sort of tapped around your eyes, which is, you know, what you're supposed to do anyway to get that lymph moving.
Yeah, but it's a very familiar sound in Korean households.
Just lots of slapping on the
skin.
face.
Exactly, you know exactly what's going on when you hear
And
that
someone's
sound.
got their bathroom door locked. Tap, tap, tap,
Yeah,
tap.
but their view is very much that skincare is self-care, so it goes further than just skincare products. They make sure you're eating healthily, you're getting enough sleep, the importance of stress and your mental health on your appearance and what it can do. And their kind of view is that it's polite to present the best version of yourself.
Yeah,
And
I
that's
can see
kind
that.
of why they do it.
Yeah.
And as I say, it's something that they enjoy doing and they get pleasure out of doing, and I don't think that skincare should ever be a chore. And
Yeah.
that's why it's important to tailor it to that person, because
No, 100%.
it can become a chore.
And does it influence the treatments that you do, the sort of
Yeah,
South Korean
so,
principles?
Yes, so certainly I think for my patients, I'm able to talk to them about ingredients that haven't quite made it into the mainstream in the UK yet.
Yeah.
So beta-glucans are one example.
Yeah.
So we all know about hyaluronic acid and how it's hydrating and lovely. Well, beta-glucans are 20% more hydrating than hyaluronic acid.
Really? Wow.
It has antioxidants
Didn't
in
know.
it, anti-inflammatory.
So why are we not all using beta-glucan serum instead of HA?
Because it's just not quite made it over to the UK
Okay,
yet.
so this is like on the cutting edge of skincare ingredients.
well, it's creeping in.
Okay,
So
I'm gonna
actually,
take note of this.
yeah, so Ren's Evercalm has got beta-glucan in it.
Okay.
SkinCeuticals Epidermal Repair has
Mhm.
got beta-glucan in it.
All the things that are very healing and very soothing. Then.
Exactly. So very nice for repairing barriers and things like that.
That's perfect.
Fermented skincare products,
Mhm.
really interesting area. So we all know about fermented foods and how healthy and good they are for you. And they found that, I mean, basically the fermentation process, it breaks down the original ingredient into these tiny little bits. And these tiny little bits are amino acids, antioxidants,
So those can then
postbiotics.
penetrate into your skin so much more easily.
Exactly. So they then get
Great.
through into your skin.
Yeah.
And I think there's some studies that show that by fermenting ingredients, you get 4 times the amount of potency than the
Wow.
ingredients in its original
That's
form.
really cool.
So I think that's
Olga's
an
nodding
area.
over there. We're going to talk about
Yeah,
fermented foods.
I'm going to
lots,
leave
I'm
the
sure.
Yeah, exactly. So really interesting area. But in terms of aesthetic treatments, something that it always surprised me that this hasn't quite made it into Western treatments yet is something called mesotox or microtox, and this is one of the most popular treatments that is done in aesthetic clinics in South
And so
Korea.
is this using toxin with the word
It
toxin?
is. So
Okay.
it's using botulinum toxin. Now, obviously, traditionally, we normally inject it quite deep into the muscles. It prevents those muscles from moving as much because we're blocking the nerve impulses that go to the muscles. And as a result, you see less movement in the face, but you get the smoothing of the fine lines and the wrinkles.
Exactly.
That's how we normally use Botox,
Yeah.
and it's great. But in South Korea, they take it one step further. They dilute it more, so it's less concentrated, and then it's injected in multiple places. So we are talking lots of injections, but it's so
how many across the
superficial.
face if I were to come and
We're
see you?
talking 50 to 100.
Wow.
A lot.
Almost like a mesotherapy or a skin booster.
Exactly.
Or something. Yeah.
But the depth of the needle is so superficial, it literally just breaches the skin.
Wow.
And when you inject it, you actually see a tiny little bleb where the Botox has gone.
So you're not actually hitting the muscles with this. You're just getting it into the top top layer of the skin?
Yes, almost. So what you're actually doing is you're hitting the very top layer of the muscle. So you're not hitting the body of the muscle, so you don't lose movement.
Yeah.
But in the top layer of the muscle, what you have is these kind of tendrils or branches that attach to this very top surface of the skin.
Mm-hmm.
And even those can create irregularities in the skin. It can make it look a little bit rough. And what it does is it sort of breaks down and relaxes those connections
Oh, we see how
all
clever.
over the skin.
Yeah.
And what you get is a kind of glass skin effect, which is
what
the
we're always
Korean
talking.
term that we always hear about.
We always hear about glass skin. And is there any downtime with this? Because if you're doing that many injection points across the face, surely you're going to bruise somewhere.
So the chances of bruising, I guess, are increased because of the number of injections that you're having.
Yeah.
You do get tiny little blebs that form. They can take a little bit of time to go down, unlike normal Botox, because you can put this under the eyes if you want to.
Oh, wow.
It will smooth out the fine lines under the eyes.
Yeah.
So you can get areas where the little blebs will remain for longer, but in general it's not too bad. We can use numbing creams if people want them. The other things that it can do, which I think are really interesting, as well as creating that really nice smooth skin effect, is because it has an effect on the oil producing glands and sebum producing glands. So you are less oily, you produce less sebum. So for people with acne, and it actually reduces flushing. So for people with rosacea, it can help with that.
So really nice things again for this sort of summery time of year when we are going to be sort of hotter, sweatier, probably more flushed.
Yeah.
That's really cool. And how does this fit in with skin boosters? Because I guess we've seen a huge rise of those in the past sort of years, and you're obviously sort of using those sort of day to day in your practice as well.
Yeah, so I think skin boosters fall into a kind of area of their own. They're doing something completely different to a dermal filler or Botox or anything like that. And you get lots of different types of skin booster, but the main ingredient in them is hyaluronic acid.
Yeah.
Which is the ingredient that gives us the plumpness and the hydration in our skin, and we lose it as we get older. There's different types of booster, as I say. So you have Profilo, which is, I think, one of the boosters that has the highest amount of hyaluronic acid in it. We have Redensity 1, which contains hyaluronic acid at a lower concentration, but it contains other things like amino acids. It contains glutathione, which brightens the skin. It contains vitamins and other things. So these are all things that benefit the skin from deeper down.
Well, they hydrate it and they give it that glow and sort of make it look so healthy.
Exactly. And they do this by boosting collagen. They boost collagen. They prevent the breakdown of fat, probably one of the only times that we don't want fat to be broken down.
I've never heard that. They prevent the breakdown of fat.
Yeah, so they stabilise your adipocytes, which are the cells that are responsible for making fat and our fat cells.
Interesting.
And it helps because as part of the natural ageing process, we have lots of different fat layers and pads in our skin, and they actually atrophy or they get smaller as we get older, and that's why we lose the volume in our face.
And that's when you start sort of using dermal fillers to then try and replace that volume that you've lost in that scaffolding. So actually, if we sort of get into a nice sort of routine with skin boosters, we're boosting our collagen, but we're also preserving that sort of fat.
Exactly.
Fat.
And I think sometimes that's nicer than, I think dermal fillers have a place, certainly. But rather than strategically placing volume in certain areas, it's sometimes nice to just have a blanket of hyaluronic acid, because it will brighten the skin, it evens out tone, helps with textural irregularities, and I would never say to somebody it's going to get rid of deep lines. They won't. They can't do that. But if you've got these very fine lines or crepiness, for example, around the eyes, it usually works really well.
But I know so many women who, wouldn't touch toxin or dermal fillers with a barge pole, yet they are all loving Profilo at the moment. It's really interesting, and their skin is glowy and it's much smoother and less sort of lined, like you say, and the crepiness isn't there anymore. So it certainly has a place. And also, we're now using skin boosters on the body, aren't we? Which is really interesting as we start to probably peel off the layers and expose sort of more of our flesh for the summer.
No, I think it's an interesting area, because anybody that kind of comes to us with laxity in the face is highly likely to have it in other areas of the body. And more recently, people are becoming more interested in what they can do for skin laxity in other areas of the body. But yes, I mean, we mentioned Profilo. Profilo have recently brought out a new syringe called Profilo Body,
I think it's just like a supersized version of the normal
I
Profilo.
think it is. It is.
Very clever
it's 3
marketing.
mils as opposed to 2 mils,
Oh God, wow.
essentially.
And it comes with a special mask that you put on afterwards.
It does, and a special template
Don't know
that
if it
guides
makes any
you of where
difference.
to. Yeah. Yes, but the principle is the same, and it does work, and that is particularly good for kind of sagging or loose skin that's in the inner arm area, but also on the abdomen. And then with traditional Profilo and traditional skin boosters, actually you can get really good results in the neck, the décolletage.
It's amazing. I actually had it all across my décolleté before my wedding, so I had sort of quite a low square cut neckline, and it was really good for softening those sort of vertical lines that you sort of get running between your cleavage, and I suppose like the dehydration lines as well, which sort of creep in, particularly areas that are very sun exposed, backs of hands, neck, décolleté, like you say, I think. Yeah.
I think they're really interesting treatments. I think they are delivering things that your skincare products can't do, because they are working from the deepest layers of your skin, and they're hydrating from those deep layers to provide structure and support that you just cannot get from a skincare product.
No, it's really clever. And final question before we move on, we sort of touched very briefly on collagen boosting, stimulation when we spoke about the skin boosters, but you also use a number of energy-based devices, don't you, in clinic? How do they fit in with the skin boosters, with the mesotox, with the fillers that you do, that sort of stuff?
Yeah, so the machines that we use in the clinic complement our treatments because they are helping to stimulate the collagen production as well. So
everything works together. You're stimulating it from all sides.
Exactly. So specific treatments that I would probably mention. I mean, we've got a machine called Exilis, which is a machine that uses radio frequency and ultrasound, and what it does is it heats the skin and the fat, and it actually tips the fat cells into a process called lipolysis, which is just the fancy term for fat breakdown. The cells actually break down.
Evacuating the fat cell.
Exactly. So it's permanent destruction of fat cells, which sounds amazing. I mean, you need to do this in line with exercise and diet. I mean, it's not going to do miracles in that sense, but it works. But in addition, because you've got radio frequency and ultrasound, it also tightens the skin.
That's interesting.
And it rejuvenates the existing collagen fibres that are there. So as we get older, the fibres aren't kind of nice and bouncy and spring. They're all a bit broken and a bit dehydrated.
They break down from the age of 26 or something, which I find completely terrifying.
Yes. I mean, by the age of, I read that by the age of 40, you've lost 25%. By the age of 60, you've lost 50% of your collagen.
And is it the same across the face and the body, or do you see sort of people losing more collagen in their body, which is why they're more worried about sort of skin laxity in certain areas, or is it fairly
No,
holistic?
I think it's fairly uniform throughout the body.
Great, so we lose everything.
Everything
goes.
yeah.
Fantastic.
Yeah, so Exilis, we've also got a machine called Morpheus 8.
Oh yes, which I've had, which is also fantastic.
Yes.
The microneedling with the radio frequency.
Absolutely, yeah. And so that modulates the fat a little bit, but because you've got the microneedling, it causes micro trauma, it stimulates your body to produce its own collagen. I think it's always nicer when you've got a treatment that makes your body do its own thing rather than you putting something externally, and that's what skin boosters do.
It's so true. It's sort of about working with our body's own natural resources and abilities, and it feels much more, I suppose, current and relevant to be sort of working in that way.
Hand rather than
And can you use Morpheus 8 on the body, or is it just on the face?
You can use it on the body. You can get really good results on the tummy, on the knees, again in this area, the neck. Yeah, you can.
Fantastic. Well, that was really eye-opening. Thank you. I learned several things there, mainly about the breakdown of collagen, which is awful. But thank you. Thanks so much, Christine, for joining us tonight. And our second speaker is Professor Mark Whiteley, who, as he introduced himself earlier, is, well, these are my words, not yours, the most sought-after vein expert. If you have a varicose vein, if you have a thread vein, if you have a broken capillary, I would always send you to Mark first and foremost. I mean, Mark, you're obviously an expert in multiple vein-related conditions, and actually Mark invented many of the techniques and the treatments that we use in sort of pioneering vein surgery today. But what are most of your patients actually concerned about when it comes to summer? Are they noticing veins more? Is it sort of cosmetic? Is it health-related?
I think the seasonal variations are the ones that you see, obviously. So it's the telangiectasia, the thread veins, and the bulging veins. Yeah. And people think about them more in summer. The difficulty is with all surgery. So unlike when you can put a filler in or something, when you talk about surgery, all surgery works by a destructive process. So we're ablating something or removing it, and we're relying on the body to heal.
Yeah.
So you actually need time for that to look good. And I always say to people, think of an appendix or a cesarean wound. It doesn't look good for 9 months. So when you really want to be doing it is September for the following summer.
Exactly.
But everybody thinks about it in April, May, June for this summer.
There's a lot of forward planning that you need to do with veins, actually.
If you're going to get proper things, I mean, if you want to just make it look good for this summer, then you need makeup. You're not going to get anything medical, because even if you're using the most up-to-date things, you're destroying the tissue, and to destroy the tissue in a way that's going to scar nicely, so that you don't see anything, that's fibrosis. You're talking for 6 to 9 months at least.
Wow. And are people sort of more concerned at this time of year of sort of facial veins, or is it like the leg veins that we're sort of talking about here?
Well, I only deal really with the leg veins. We have a separate thing looking at facial veins, with the exception of some of the new things we're doing. So the aesthetic doctors tend to do the little thread veins on the surface. And the nice thing with thread veins on the face is thread veins on the face are just thread veins, or more commonly little arterioles.
Yes.
As soon as you're under the heart, it's completely different.
As in from the heart down.
Yes. Yeah, so as soon as you've got the gravity, so when you look at the physiology of the body, it all starts at the zero pressure is at the heart. So when you stand up, or even sitting like this, the pressure in your ankle, if you're not moving your ankle veins, is about 1 metre of water.
Wow.
So the point is, when your thread veins in your legs, if you try and treat them the same way as you would treat them on the face, you're just not going to get good results. So as a rule of thumb, and a general rule, if you've got thread veins on the face, it's fine to just see them and treat them. And you treat them with IPL, with electrolysis, with laser, because it's what you see.
Yeah.
When you're as soon as you're under the heart, you've got this column of blood, even if your valves are working. It's even worse if they're not working. And with that, you need to have a venous duplex ultrasound scan. You need to find the underlying cause of the pressure. You need to treat that first, and then you need to do the treatment, which is almost always sclerotherapy. So you should never really do sclerotherapy on the face if you can help it. And you should never really do laser and all the other things on the skin of the legs.
So sclerotherapy, just to recap, what exactly does that entail?
So sclerotherapy is, scleros means to make hard, and therapy is a service done to the sick. So it comes from basically injecting something into a vein to make it hard, which means inflamed to go away. And we use two main different sorts in the UK, detergent, and some people use some of the irritants or other ones. What you do, you're injecting it either as a liquid or a foam, and if you're doing it properly, you can do it just direct vision with sort of light if it's into thread veins, but more commonly nowadays you do it with ultrasound control, so you're getting into the veins underneath it.
Right.
The trouble is they're all inactivated by blood. So what we do nowadays is we tend to make them into foams, so we mix them with gas, so that it's a bit like having a shaving foam. So when you inject it, it pushes the blood out of the way, and so all of the drug goes into the wall. The trouble is then the foam disappears within 2 minutes, and your vein doesn't die for 3 weeks. So in that meantime, you've got to keep the blood out, or else you get brown stains. And when you hear people getting brown stains after sclerotherapy, it's because they don't think of that 3 weeks, and that's why you have to wear compression.
I thought this is where the compression stockings would come in.
And it's the horrible thing, we're all looking for glues or things that don't need that. But at the moment, as soon as you've got a dead vein, if blood goes back into it, it clots and you get brown stains.
Yeah, exactly, and that stains the skin for some time, obviously.
Yeah, it can be permanent, but it's usually just for months, if not years. So the idea nowadays is you do sclerotherapy in the veins, compression for 3 weeks, which is why you start in September and do it over.
Exactly. This is where the forward planning with the vein treatment really comes into its own, because you don't want to be in those compression stockings in the heat of summer.
And the other thing about it is also sclerotherapy doesn't work. And we published a big paper in 2014. We took a lot of veins out of volunteers under ethics committee, of course, and we treated them with different sorts of sclerosis. We found that if the vein wall is more than about 200 microns, sclerotherapy doesn't work. So what that means is, if you've got thread veins or the greeny veins, sclerotherapy is brilliant. If you've got varicose veins or the ones inside, it doesn't work.
This is why I send people to you, because you just talk about veins in a way that you're so passionate about them. You know absolutely everything. But you obviously go into immense detail as well, and you obviously said that doing these ultrasounds is really important so that you can see what lies beneath the surface. 'Cause so many times I've had, you know, friends, family say to me like, oh, I've got some thread veins, I'm going to go and get them lasered off on my legs, and they're normally the people that I then send to you to say, actually go and get them checked, because often it is such an indication that something has failed in the sort of valve network.
So there's a research paper in 2000 by Somigen, and he was the first who looked at it. And if you look at 100% of women who go to aesthetic clinics for leg thread veins, and you scan them properly, 89% have underlying varicose veins.
Oh my God,
and that means that only 11% are going to get a good result by having a treatment that is seen from the outside. So this is where aesthetics is so different from venous surgery, because venous surgery, you don't trust what you see unless you've got an ultrasound.
Yeah.
In aesthetics, it's all about what you see and trying to make it look good on the surface. And
exactly.
they're both right approaches as long as you use them in the right place.
Yeah, exactly. And the last thing you want to do is spend all that money and time and effort to get some sort of veins zapped, and then they come back because you actually didn't get the underlying cause. I mean, you mentioned earlier that you've got sort of newer facial vein treatments. Are these the ones to remove? Because you and I have spoken about this sort of outside of these walls, sort of the protruding veins that some of us get in like the temples and around the eyes and forehead.
So, absolutely. So most aesthetic doctors will be very happy with the little veins to zap them with this, that and the other. And especially the little greeny veins here, they often use Nd:YAG laser. And then you get to a point where the laser is not powerful enough. And the reason being is the veins, most people don't notice, but veins are white. They're not green or blue or anything. That's only the blood that's inside them. So what happens when you want to destroy a vein with a laser on the outside, you actually are pumping energy into the blood inside the vein, which is the colour, and then that has to boil, and that heat has to be transferred back to the wall. Now if the blood's flowing too fast, or there's too much blood, you can't get enough energy into it in time, so it's never going to work. So there's a size of vein that's just too big to treat, and at that point, most aesthetic doctors just say, it's too big.
Yes, exactly.
So we always come in with our research at points where everyone else says you can't do it. So what we've developed we've published, there's these big vertical veins here. Angelina Jolie very famously had one. And for years people have tried to laser them. You can't do anything about them.
They always come up in the summer when you're very hot, or when you're smiling in a photograph.
Yes, so it's warm, so it's summer, it's warm, it's alcohol, it's exercise, and it's smiling. Because when you clench your facial muscles, the venous drainage actually is via the facial vein here, and so when you clench this, you actually tourniquet, and it therefore
and then it
up.
stands out so much more.
You smile for a photograph, but that's when it's worst of all, especially in summer, as you say.
Yeah.
So we started saying, how can we get this? You can't get the laser deep enough to get into it. And a couple of my American friends who've tried it have actually caused pits in the skin where they've tried to do it from different angles.
God.
So 5 years ago we very bravely had some volunteers, we started removing those veins surgically, but just the same way is why we never now remove veins in the legs, they grow back. And so in leg veins now we ablate them where they are, you don't take them out. And if you ever take one out, you have to go back and ablate the bits that grow back again. So we know that veins grow back if you remove them. So two and a half years ago, we invented a way of putting an endovenous laser. So you lie the patient backwards, local anesthetic, you put this diddy little version of a laser that you'd use in the legs, and you put it inside the vein under ultrasound control, pass it down to the eyebrows. You then have to put lots of local anesthetic to push the skin away from it, and then we've got some cooling processes to save it. And then you use a special wavelength, and we've just published a paper in MedSci Lasers showing that if you use a very high wavelength, so one called a 1940, which is not the standards of 40 centimeters. I don't want to get boring, but basically what happens is
technical.
the laser, you want the laser that heats very quickly and doesn't spread too fast. So you've got less risk of skin
that makes
burns.
sense.
And then you use a set amount of power and you actually ablate the vein, and you destroy the vein in situ where it is with just a needle hole here, and you can do it 2 or 3 or 4. Then we've found for the ones around the face that are big and bulging and green, and sometimes over the eyelid and down the face, still the best thing for those at the moment is phlebectomy, and we just put local anaesthetic around them, but we have a special technique where you go into the angle in the line of the thing, so you don't go straight across the skin, you do a little flap up, and we remove the veins there, and those ones actually do very well. You don't you don't ever try to do sclerotherapy on the face. So we'd like to come back and do a little bit of sclerotherapy to stop them regrowing, but it's too dangerous to do sclerotherapy on the face in case any leaks into the veins.
Yeah, because those are really important vessels there, obviously.
They can go,
what's the downtime on these sorts of procedures?
well, surprisingly, it's actually reduced less. And we've published a paper on the vertical forehead veins, and we've published a paper on the artery, the bulging thing here, which I haven't talked about. We've published those two, and we're just about collecting our figures on the ones here. And so the downtime tends to be, for the vertical forehead veins, tends to be about 3 days, 2 days for bruising. But then because you've got a lumpy dead vein, it does still bulge for 2 or 3 weeks afterwards. But then again, compared to having a vein that gets bigger every time you talk, it's nil.
Exactly.
The little ones that we phlebectomise here, we use lots of adrenaline around and lots of ice afterwards, everything you can possibly do. And I think really for the little nicks to disappear, it's usually 4 to 6 weeks, and for the bruising, it's usually about 2 weeks.
That's really not as bad as I thought.
No.
Moving back to sort of leg veins, because I think they're obviously a sort of huge cause for concern in summer approaches. I feel like there's so many sort of myths going around about actually how we create these. I mean, I'm sat here with my legs crossed. I don't know if that's like, they say don't sit with your legs crossed because you're going to get varicose veins.
That's rubbish.
Okay, I'm fine then. That they're hereditary, that, if your mother had them, you'll get them. Is there any sort of rhyme or reason to any of these myths? Or what is fact and what is fiction then?
So basically what happens, what we know is they run in families. So it's what's called familial.
Yeah.
So that if you come from a family with lots of varicose veins, you're more likely to get them. However, they can't be genetic, because otherwise all your veins on one leg and the other leg would be the same. You get them all. You don't. You get varicose veins in one leg, not the other leg, or you get great veins or the other. So it's not just genetics. There is something else that happens, and we don't know what. One thing, if you don't mind me just wittering on for a second.
Please, witter.
I love looking back to why we have these stupid things that people think are logical.
Yeah.
And the crossing the leg one is very interesting. So back in the 1950s, 60s, 70s, what used to happen, people had what's called nightingale wards. And you lie in the bed and people walk at the end. And of course, nobody likes somebody walking with their legs straight. So they always cross their legs, because for modesty. So what used to happen is the nurses used to go along and sort of see all these patients across the legs. And because people had cancers or big operations or other things, they got deep vein thrombosis, so they got pulmonary embolism. And that was because they're having general anaesthetics or they were sick or they were ill. It's nothing to do with crossing the legs.
Yeah.
So the nurses got used to going along and saying, when a few people had died from pulmonary embolism, went up and said, don't cross your legs, because the idea, they thought it was pressure on the calf.
Oh my God, wow.
So they used to slap the legs and say, don't cross the legs, don't cross the legs. And when the patient said why, they said it's for your veins. But they were actually talking about DVT and pulmonary embolism, which isn't true. Nothing to do with varicose veins. And somehow this has morphed in the general population to being it causes varicose veins.
But the thing is, unless you're a venous surgeon and you have your sort of brain, we don't necessarily know all of the differences between all these sort of different veins and issues and whatever, so I guess it's easy to lump them all in, but that's very refreshing to know.
No, crossing legs has no effect at all. If just crossing your legs caused a vein problem, we would have evolved very differently.
Yeah, that's probably true.
We would have had
what about things like the amount of exercise you take? Does that have an impact?
That's really interesting. So what happens is, and the evidence for this is a bit of it's in wrong. So it's quite interesting, because there's some people that say the fatter you are, the more varicose veins you get, and that's untrue. What happens is the more exercise you do, the less you deteriorate. So you still get the varicose vein. So if you had 2 people with a lot of reflux in their legs, and one is a couch potato and one is an exercise freak, the person who does more exercise will actually deteriorate less. They'll have bigger and bigger and bigger varicose veins, get worse, but they won't get the swelling, the brown staining and leg ulcer until later. And there's been very good work done by a man called Johann Chris Rag, who's a friend of mine in Germany, who's got a very, very good clinic like ours and produces lots of PhD students like we do. And what they've done with ultrasound scanning, they've looked, and people who walk for less than 2 hours a day get little clots on all their valves, which they think start destroying them.
Oh, wow.
Whereas people who walk with more than 8 hours a day, like postmen, have absolutely clean veins completely. Now, it doesn't seem
to... Don't tell us we have to walk for 8 hours.
Or become postmen, no. So what happens, it is a good thing to keep on moving, keep your legs moving. Exercise is the most important thing. Yeah. It doesn't cause varicose veins, as I said, but if you are prone to varicose veins, it's the thing that will change how quickly you deteriorate.
Okay. So it's more about sort of managing that deterioration rather than just...
If you've got venous reflux, you are going to deteriorate, full stop. And the only treatment for it is to get them properly treated. However, how quickly you get symptoms or signs depends on your activity. And where weight comes in is actually people who exercise more tend to be less heavy.
Yes,
so when
exactly.
so then you look this correlation, you correlate people with vein problems with weight. You're not actually comparing the right things.
Yeah,
and
that makes sense.
It's one of these sort of things that you see in science all the time where people find an association which isn't causative.
And when it comes to the symptoms, because obviously we were saying earlier that so much of what goes on with the veins is sort of lying beneath the surface and we can't necessarily see if there's an issue or not, but what are the symptoms that we then need to be mindful of if there is a varicose vein or a network of them developing?
Well, the figures are really interesting. So something like 15 to 20% of the population today have got varicose veins and can see them.
Yeah.
But another 15 to 20% have varicose veins and can't see them. And we used to call that superficial venous incompetence or superficial venous reflux, and there are all different names for it. And in my book in 2011, I called it hidden varicose veins because people understand it better. And those people are the ones who are at risk because they get the swollen ankles, the red stains, brown stains, and leg ulcers and clots, but they never knew they had varicose veins.
Wow.
So what the NICE guidelines have now said is if you have varicose veins or suspect that you might have, you must get a scan if you have the following, and it is any aching in your legs, tired legs, heavy legs. You don't get pain from varicose veins unless they thrombose. But it's that general feeling of bad, which gets better when you put your legs up. Or if you have swelling of the ankles, red stains around the ankles, brown stains around the ankles, leg ulcer, thrombophlebitis, which is clots in the veins, or you bleed actively from the veins. And that's absolutely recognised. Any of those, your risk of having surgery with the new techniques is vastly less than your risks of getting worse if you don't have it.
But it sounds difficult because, you were saying heaviness and aching legs and they improve if you put them up, but that could also be water retention, couldn't it? People who are just prone to sort of a bit more water weight in their legs.
And that's why we don't operate without a duplex scan. So what happens is if you suspect you've got it, if you've got big bulgy veins, you know you've got it.
Of course.
If you've got just heaviness, you need a scan to find out which it is. If you've got heaviness and eczema around your ankles or brown stains, you're going to have varicose veins or hidden varicose veins.
So eczema around the ankles as well is a sign.
Yeah, anything like that.
And final question, I suppose it all comes down then to having these sort of checkups, these venous ultrasound scans. Is that something we should be trying to do on the day-to-day, or are we only ever really going down that road if we suspect that we have sort of issues with veins?
I think you should only do it if you suspect it, because the guidelines say that if you're asymptomatic, there's no advantage yet. So there's no point in finding it if you haven't got it. So a lot of my patients say, can I come yearly for a checkup? And, commercially you might want to do that, but I don't do the commercial things. I think it should be done on thing. So I say to people, if you're getting any signs, you're seeing any of those problems, or varicose veins, or throat veins, or symptoms, then get a scan. And I think that's the correct way to do it.
No, I think that sounds very sensible. Thank you so much, Mark. That was fascinating, as always. Where are my notes? Third and final speaker, Olga. Thank you so much for joining us. As Olga introduced herself, she is nutritionist, extraordinaire, TED speaker, and you work here at the Lanesborough. You also Bodhimaya's head of nutrition, which is amazing. So you obviously work with patients and clients with all different sort of ranges, don't you? What are the main concerns that your clients have when they come to see you, would you say?
Yeah, very good question. Thank you. Usually, general public associate nutritionists and nutritionists help only with, say, vitamins or prescribing vitamins tailored to you specifically, and say weight loss, but that's probably it. But it's so much more than just that. Because I see a range of different symptoms in clinic, from obviously resistant weight loss to IBS type symptoms, any kind of digestive disorders, skin conditions, even circulation conditions, water retention, things like that. It's just, even hormonal imbalances, polycystic ovary syndrome, thyroid function, adrenal function. So all the body systems, they are obviously very dependent on nutrition. We are what we eat, don't we? So
I often think that the nutritionist is the person that we go to as the last port of call. Often we've tried a lot of Western medicine, GP, and ultimately we have to make some lifestyle changes that bring us to the door of somebody such as yourself.
Yes, absolutely. Yes, I'm a very good example of that. When I moved to the UK, I started to get really, really bad eczema all over my face. I couldn't wear any makeup at all. I was working in the office at the time. I had a different career at the time.
And I've tried everything. I've been to all dermatologists, but the standard treatment for eczema is steroid cream or emollients, or maybe there is a light therapy. Side effect is, cancer of the skin, which we don't want to do, obviously. So now that I've done hypnotherapy, I've done acupuncture, I've done homeopathy. I've tried everything. I've been to the Dead Sea, to their clinics, and nothing helped. Guess what helped? Changing my diet helped. And as soon as I was in remission for the first time, and I was in remission for 9 months, my skin cleared up completely. And all I did was just a dramatic change of diet, because all I was eating before was gluten, dairy, sugar, coffee, alcohol. Yeah, that's it. That's the standard British diet, isn't it? So and then, I never questioned it, of course. It never dawned on me. And then I got my hands on the book, I think it was Patrick Holford, Nutrition Bible. So Patrick Holford is the founder of the Institute for Optimal Nutrition. This is where I actually went to study afterwards. And and I excluded all of these things from my diet. And here we go, remission.
And look at how glowy and healthy you are now.
And but my eczema did come back after 9 months, although I did stay on the same diet. And I thought, okay, there's something I'm doing right, but I just don't know what I'm doing at all.
Yeah.
So this is why I decided to change my career, and this is what inspires me to the day.
I didn't realise that's how you got into it. That's so fascinating. Do you find at different times of year that people come to you with different concerns, or are we fairly even throughout the year with nutrition concerns?
Weight loss is usually, yes, in springtime or just after Christmas. Yeah, it's a big concern, yes. But all of the other things, it's all year round, yes.
And how have the past few years, sort of pandemic particularly affected the conditions that people are presenting with when they come to see you? Have you noticed that having a bearing on what people are coming to you with and complaining about?
Absolutely, yes. And that's really concerning, because you probably know that mental health did suffer a lot.
Yeah, exactly.
And people were they didn't want to talk about that they were on antidepressants before COVID started. But now they're quite open about it, and now they are asking for help. Yeah, and it's just a wave of clients who are depressed and anxious, mood disorders, a different kind of, everything on the spectrum, really.
Well, that makes sense also, because so much of our happiness, our serotonin, comes from the gut as well. So if we're not if our gut isn't functioning properly, or the two must go hand in hand, surely.
Oh, absolutely. Yeah, there is a very clear brain-gut connection that's been researched in recent studies, and we're now seeing quite a lot of. We know for sure that whatever happens here, our gut microbiome is almost our second brain. We can actually say it's our first brain, because these bugs, they rule us, they control us, they control how we feel, they control what we do and how we behave. And this is a fascinating, new area of research. By doing the gut microbiome test, I can actually see if a person is depressed, because there are certain characteristics of the gut microbiome that can show depression or anxiety. And there was this really fascinating study that was done in the 60s, a long time ago. So we kind of knew there was a connection, but it was never investigated in that way. Yeah. It's called mice study. So they obviously did all of the research on mice, and they infected mice with toxoplasmosis, which is a parasite. And the effect of that was that mice lost fear of cats completely. Really? And they actually started loving cats. So they started running after cats, and as a result, they get killed, right? Oh, and this is how the parasite gets into the cat. Very clever, right? By hijacking mice's brain completely, changes mice behavior completely, permanently.
Oh my goodness.
We knew this a long time ago. It was never investigated. So now we're researching everything. And now if you do a stool test with your microbiome analysis, I see very low diversity of gut microbiome, I can definitely say you're either anxious or depressed. So it's very easy to see.
That is so cool. And so that's how you figure out what the gut microbiome is doing. It's a stool test, or are there blood tests that you do, or?
No, for the gut microbiome, you can only do the stool test.
And why is it so important to have that sort of diversity of the gut microbiome?
Very good question. Still being investigated. We still don't understand a lot of what's happening here. But we know that the certain types of bacteria, especially the beneficial type of bacteria, you probably heard of Lactobacillus acidophilus or Bifidobacterium. So these two are one of the two most researched bacteria that we have in our guts. And if you don't have them at all, you're not producing specific metabolites or compounds that then they travel to the brain and make you feel happy. Like serotonin, for example. We know that 90% of serotonin is actually made by the bugs in our guts.
Isn't that clever? And when it comes to sort of the diversity of the microbiome, are there things that you can do to influence it? Is it down to like the foods that you eat, the lifestyle changes you make? Is it like environmental stress? Like how can we, try and cultivate that diversity and get our guts functioning as they should be?
Yeah, this is there's so many different things you can do. Where do I even start? I mean, first of all, the negative effects of certain things like artificial sweeteners are really, really bad. So I would rather go for full fat Coke, as they say, than artificially sweetened. Yeah, definitely.
Really, and they've done studies to show the sort of negative impact on the gut microbiome through the sweeteners.
Yes, absolutely. Yes, I mean, there's obviously different types of sweeteners. What's it called? The stevia one is actually okay-ish, but all of the others are probably not a good idea. Of course, yes, too much sugar in the diet negatively affects microbiome. Antibiotics, we know antibiotics have been overused, and now I'm seeing a lot of clients in the clinic who have 5-10 antibiotic treatments per year. And of course, when we do the gut microbiome tests, they deplete it completely. Exactly. And we know there is a link between antibiotic use and depression. No surprise here, right?
Yeah, exactly.
We also seen lack of sleep negatively affects it. Lack of vitamin D, lack of sun exposure, lack of nature contact also negatively affects gut.
Yeah, there's really interesting studies into nature now, isn't there? Sort of how it really enhances longevity just from being present in it. And I suppose there's so much that we sort of still have untapped.
Yes, absolutely, yeah. And all of the beneficial things, of course, we all know about probiotics and probiotic foods, fermented foods. They contain live bacteria. And they don't necessarily populate our gut, but by kind of going through the gut, they help us absorb nutrients, they help us make vitamins that we then absorb, they help us digest food better. So it's every single culture has some kind of fermented food in their culture.
Yeah,
and especially I know Koreans, they have a lot of really good fermented foods. Yeah.
What are the fermented foods we can be getting into our diets then, the Korean ones? Or, I mean, there are loads in sort of like Germany and Austria, that's all very popular.
Yeah, well, anything from kefir to just probiotic yogurt, any fermented vegetables, like Japanese culture has a lot of fermented vegetables.
Yes.
And they actually ferment them to the point where you can't even recognize what it is.
Yes.
It tastes completely different. And you can obviously take probiotics, but again, there's so many different types of probiotics on the market, and you never know which one's right for you.
Yeah.
So by doing the stool test, we can actually tailor them a bit better for you.
So there's obviously a sort of variety of different probiotics that you then put your clients on. Yeah. Are there any that you recommend for specific things, or is it incredibly bespoke?
Now it's getting more bespoke, yes.
Right.
So like for example, there was this first probiotic that just been released by one of the supplement brands here in the UK, in Vivo Clinical. And because you can't really have any claims like say, oh, this is a probiotic for depression. You can't say that. Yeah, it's just not allowed in the UK. But they were able to prove from some of the studies that the types of probiotic strain that they've included in the probiotic capsule actually did improve well-being, mood, depression, and anxiety scores with some of the clients through the trials, of course. And now the probiotic is actually called Mind and Mood.
Oh,
so
really?
they can claim that, yeah.
And they often say that your probiotic has to be kept in the fridge. Is that sort of still the case?
Not necessarily, no. What we also, the research actually shows that probiotics don't have to be alive.
Oh really? I
to
thought that
have
was the point. They
beneficial
had to be
effects.
alive, otherwise you weren't getting the benefit.
Some of them, yes, but
Right.
others are not necessarily. Yeah. But it shows a very similar or even better effect when they are cultivated and then killed, freeze-dried, and put in a capsule.
And you know how you said earlier that you can tell if somebody is depressed by assessing their microbiome. Can you tell other things about their health? Can you tell if they're going to be prone to weight gain or weight loss or inflammatory conditions or disease? Like, is it that sort of helpful for you?
Yeah, it is getting that specific, yes, through research. There are 4 different stool analyses on the market that are available to professionals like doctors and functional medicine practitioners and nutritionists, and 3 of them are coming from the States, and 1 is done here in the UK. They all kind of slightly different. So I would probably, if you're complaining, say about weight gain, for example, or resistant weight gain, then I would probably recommend for you to do the Genova one, because this is from the States, because they would test for Akkermansia. And Akkermansia is a bacteria that helps with our metabolism. So if you're missing Akkermansia completely, you're probably more likely to put on weight. Like, for example, you and me are on exactly the same diet. One person's losing weight, the other is one gaining. How do you explain that? Yes, it does happen. We know this, and we can now explain it through the gut microbiome, which is totally fascinating.
So then you could prescribe, once you've made that assessment with your patient, you can then, or your client, you can then prescribe them a very specific strain of probiotic, or you create like fibre blends and things as well, don't you? Which are quite unique.
This is a new development, actually, what we're seeing in the research. Because there's a lot of different trials are done for probiotics and for specific condition. For example, there's probiotics and skin link, of course, we know about it. Probiotics and gut disorders. And we even have now probiotics specifically for autistic spectrum disorders.
Really? Wow.
Yeah, so even that, they're being investigated, specific strains. Sorry, what was the question?
Oh my God, I've completely forgotten as well. I think we were saying, do you have a sort of more specific probiotic or fibre blend that you give to people?
That's right, yes. So, and most of these trials with probiotic supplementation don't necessarily show a beneficial effect. And we're kind of questioning, are they working, are they not? Some people do get benefits, some people don't get benefits. So why? It's all about the how we look after our gut microbiome. It's all about the environment inside of our gut. It's all about the health of the gut lining. Okay, so we need to have a very healthy gut lining, because it's like a room. I'm a bacteria, I'm coming to this room. It's lots of friends, it's lots of food, it's nice temperature, light, furniture, I'm staying. If none of that is present, I'm out, right? So I'm not gonna stay here. And especially if there are some enemies sitting here producing some toxins in the corner, so definitely I'm killed, right? And some bad type of bacteria can produce lots of toxins that can make us depressed and can kill beneficial bacteria. So, but what we're seeing in research now is that fiber, we know that we don't eat enough fiber in our diet, and the government recommends about 30 grams per day. To give you a perspective, so it's 100 grams of lentils will give you about 8 grams of fiber. So you would need to eat quite a lot of vegetables, fruits, to get that fiber. The fiber is what bacteria uses to eat, right? This is what they ferment, and they produce beneficial metabolites or chemicals using fiber, right? And the research is now focusing on how we can feed specific types of bacteria so they grow naturally, instead of actually putting probiotics, right, that may not survive, right? And this is showing a lot more beneficial effect. Like, for example, there was this trial only several months ago on depression and anxiety. They used galacto-oligosaccharide powder, or the prebiotic powder or fiber, and it showed more beneficial effect than antidepressants.
God, that's incredible,
That's
isn't
incredible,
it?
yeah, because it grows the bacterium in the gut, the bacterium produces serotonin, simple as that.
So how do your fibre blends work? Do you create these bespoke for your clients?
Yes.
I mean, this isn't just about like get more whole grains into your diet and eat some like Special K. This is like the real deal.
Because we all have very, very busy
Special K
lives.
probably is not on your menu.
It's even for me, if I'm very, very careful with my diet, I'm doing my best, it's still very difficult to get 30 grams of fiber per day.
Yeah, of course.
And try to chew through a couple of kilos of broccoli. It's no. So yes, it's a shortcut. You just take a fiber, blend, supplements, and you feed your gut microbiome that way. Yeah. So there's so many different types of fibers, and now we're seeing a lot of research coming out to tell us exactly which bacteria grows from which fiber, which fiber feeds what. So there is inulin, you probably heard of, fructooligosaccharides, FOS they call them. So FOS is an ingredient in lots of probiotic supplements. GOS, galacto-oligosaccharides. And there is glucomannan, which comes from cognac powder, right? So cognac is a vegetable, a root vegetable, and that has shown beneficial effect because it grows Akkermansia and helps people lose weight as a consequence. Specifically for Akkermansia as well, there's a brown seaweed powder that is used to grow Akkermansia. And very interestingly, recent research showed that cranberry, freeze-dried cranberry, grows Akkermansia. And I've tried that in clinic, and it does, yes. So I had lots of clients who didn't have at all any Akkermansia present, and we managed to grow it to very, very high numbers just using the fiber blends without even any probiotics.
And that's so nice as well, because it's such a natural thing, to be getting fiber into our diet, and if you can create such incredible sort of effects as a result of really balancing that, that's brilliant. Where do hormones fit into your approach? Because obviously a lot of conditions, thyroid, PCOS, they can really sort of contribute to that weight gain, that imbalance in the gut.
Yes, absolutely. For thyroid and PCOS, there are several different blood panels that we use. Of course, we need to first establish what's going wrong, right? Because for thyroid, if you go to your GP, they will only test TSH, thyroid stimulating hormone, and maybe then one of the thyroid hormones, which is T4 normally. There are 6 of them that we test. So if we go through a private lab, it's 6 things that we need to test. We also test antibodies just to see if there is any autoimmune basis in your thyroid. I'm seeing a lot of autoimmune conditions currently. There's something going on with, we think it's linked to gut microbiome somehow. There are some bacteria that can trigger autoimmune conditions, and there are so many different types of autoimmune conditions. So thyroid can be autoimmune. This is when your own immune system is attacking your thyroid mistakenly. We don't know why it's doing that. It's like type 1 diabetes, your immune system is attacking your pancreas, and you can't produce insulin anymore. Or psoriasis, that your skin is getting attacked by your immune system. And when we do one of the gut stool tests, we can see if you have any autoimmune triggering bacteria in the gut, and then we try to get rid of them, and that should improve your immune system function. So less attacking of your body, let's say. We can't say, and we're not allowed to claim anything because we're not doctors, right? So only doctors can treat, nutritionists can't treat. We can support and optimize, maybe that's as far as we can claim it.
Yeah, exactly.
But we're doing a lot of this kind of, I don't want to say experimental things. They're not damaging, obviously, anything. There are no side effects, but we will try to do anything possible to try to balance your immune system back to normal, and hopefully it will stop attacking your cells.
Exactly. It's the sort of first thing that you need to get under control in a sense, isn't it, your immunity?
Yeah, absolutely. And then with PCOS, of course, we need to see, again, is it high testosterone? What's the reason why? What is the problem? Is it high insulin? Is it your blood sugar, not balanced properly? Could be simple as just blood sugar regulation. So we need to see, if you're ovulating, so all of these things,
It's really understanding sort of every system in the body, like you sort of said at the very beginning, and sort of really digging around and understanding the blueprint that creates that human being or that individual, and then just working to optimize them, isn't it?
Absolutely, yes, absolutely.
And final question, what is the one thing that probably all of us in this room could do that would optimize our gut, our microbiome? Is that a really difficult question to pinpoint?
Well, no, not a difficult question. Of course, we're all very, very different.
Yeah,
and
exactly.
It's not one diet or one thing that you do that will work in exactly the same way for every single person. Absolutely not. There's no perfect diet. No, absolutely not. You have to find your own perfect diet. But something that I did research for the TED Talk, actually, that I did a couple of years ago was intermittent fasting. And there was this, I found this amazing trial. There's this fasting clinic. I think it's in Austria or Germany. Booking there. You probably heard of that.
Booking or Wilmy.
So they do a lot of different fasting regimes there, and people can go and fast there from 3 days to 21 days in one go. And they did assessment of all of the body system. It's not just for weight loss, it's to optimize your brain function, it's to reduce anxiety, depression. And they've actually found that anxiety and depression did reduce dramatically after fasting. So fasting, what it does to you, we don't have confirmation yet through research, but there are some theories how it works. When you fast, there's some kind of cleaning systems turned on in your gut. And that boosts your gut diversity, gut microbiome diversity. This is exactly what we want.
Back to the microbiome.
Yeah.
I mean, but it also sort of triggers this sort of cell death, doesn't it? The intermittent fasting, where the body sort of just gets rid of any old dying cells, and then you've obviously got all the space for fresh new cells to come through and feel better about.
So it's one of the best things that you can do for anti-aging. Yes, exactly. So and there's different types of fasting styles or regimes that you can do. From the basic one that I think everyone can do is 5-hour fast between each meal. So it's actually just 3 meals a day, normal eating. But you have to fast nothing that raises your blood sugar for 5 hours in between the meals. So you have to count 5 full hours. Or then, of course, everyone knows about 16-8. So this is when you fast for 16 hours overnight. And there's another one which is 5-2, also being looked at in the studies. A bit more difficult to do. This is what I'm getting from the clients.
That's the 5-2 diet, where you
5-2,
sort of have 2 days where you only eat 500 calories a week or something.
Yes, that's right. But what the clients actually saying that as soon as they start eating, it's so much more difficult for them to control this 500 calorie per day.
Yeah, it really is.
So they prefer not to eat at all.
What do you personally do? Or are you an intermittent faster yourself?
Yes, I do 16-8 every day. Yes.
It's a bit more sustainable, isn't it? Because you can basically have a big breakfast and lunch and not have supper before you go to bed, or you can just skip breakfast and do a lunch and dinner, and then you're sorted.
Of course, but be careful because there are some contraindications. Of course, if you're on medication, if you have any history of eating disorders, of course, if you're pregnant or breastfeeding, no, absolutely not. And also thyroid or adrenal issues as well.
I guess if in doubt, ask somebody such as Olga. Thank you. That was really, really interesting. And yeah, I think that sort of brings us to the end of tonight's sort of panel discussion anyway. We'll definitely open up the floor to any questions that anyone has. But yeah, just a big thank you from me to our amazing panelists, because I think it's really interesting, because I think actually all of you really sort of underlined the importance of the forward planning and the thinking about the seasons, but all of you actually very much focused on this sort of investigative approach as well, whether it's understanding your skin, your veins, or just your gut. Actually the work that each of you does is really sort of to deep dive into your individual patient. And I think that's really key, no matter what time of year it is, frankly, whether it's summer or winter. So that was really, really helpful. Thank you, everyone. If you do need to scoot off when we start doing questions, please do run out. Don't forget to leave your referral cards if you've made any notes on there, and we also have the goodie bag for you, so they'll give that to you at the cloakroom as you come to leave, and it's a good one, so don't miss it. Were there any questions in the audience? If there were, you can just chuck your hand up and I will come to you. This lady in the front.
Thank you all the talks are really inspiring. Olga, how do you go so far with like a reductionist diet? So for example, if you're targeting the microbiome for a reason such as acne, so they'd say like stop dairy, but then they'd say drink kefir. So they're saying stop dairy but actually drink kefir, which is fermented dairy, of course, similar to the way that if you've got acne they'd say take antibiotics, which is then destroying the gut microbiome. At what point do you kind of decide which route to follow?
Yes, testing, of course. We need to understand why you have acne. Maybe it has nothing to do with dairy or dairy consumption at all. Maybe it does, because dairy can contain some hormones, for example, or it could drive your insulin resistance, for example. So yeah, just testing. So you have to be very precise. And why antibiotics help is because we also know that some of the bad type of bacteria can cause acne. So when you take antibiotics, it kills bad bacteria. You had better. Yeah.
Is that a big concern of patients who come to see you, acne and sort of skin
Yes,
difficulties?
very, very, yeah.
What would your thoughts be, Christina, on acne and sort of managing that?
So I think actually we are trying to use antibiotics less now for acne, which I think is a good thing. We were overusing them. We were using them for too long, and actually what we found was that whilst patients were on the antibiotics, they had really great results, but actually there's quite a high rate of recurrence. So I think
as soon as you come off.
Exactly, and so I think it's important to strip right back, and I think you're right, what we've all said complements quite nicely, because Olga's right, so for myself, I actually suffer with acne.
Really, your skin is amazing from where I was
But it's taken a long time to get here, but it's a balance of changing my diet, cutting out dairy and milk-based products, but also introducing a probiotic. So I think that there's quite a lot of evidence to show that the link, as Olga's quite rightly said, that's really helped. I've been on antibiotics. Yes, they really helped, but as soon as I came off, it all came back. And then I think if you've got the right kind of basis, and then you get your skincare regime just right, you can get a lot from that.
That's when the magic happens. What is the link between dairy and acne? It's always the thing they say to cut out.
Yeah, there is a big link. Yeah, some research shows that there is a big association. It doesn't prove causation, but there is association. Yeah. And it does help sometimes. Yeah.
Was there another question I saw of this lady here?
Christine, hi. The glass clear face or whatever.
Glass skin, yeah.
Glass skin. Is that in the UK or coming to the UK?
So there are, I think, clinics that perhaps do offer it in the UK. It's definitely not something that's well known or well established. It's something that we are introducing in our clinic, because it's something that I want to bring across, and myself and my colleagues can do that.
I think it's a big trend, isn't it? The sort of glass skin. Everyone seems to be talking about it, but it's actually finding a practitioner who sort of does it properly and safely.
Exactly.
Lady at the back. Hi.
Thanks for everyone. One thing that I particularly suffer from in season changes is sinus pain and blockages.
Oh, that's interesting.
And I've read online, just through kind of some very amateur searching, that there can be links with dairy and potentially like dietary intolerances. So I wonder that Olga, is that something you've heard of, a particular link with the sinuses from nutrition?
Yes, definitely. So in the stool test, we check something we call secretory IgA, and these are the immune soldiers, let's call them. Yeah. So their job is to protect us from any invading pathogens, and we have mucous membranes where this secretory IgA are working on, right? So this is how everything kind of gets into our system. So when we see signs and symptoms like sinus infection and constant nose dripping, there's something to do with your mucous membranes.
Okay.
So, and something to do with the immune system, maybe being a bit more overreactive for some reason. So obviously there could be a lot of environmental triggers that could do that to our immune system. But again, it's working with the immune system, so it's not supposed to react that way all the time. It needs to be kind of calmed down, right? So we can then work with the immune system to reduce those reactions. Yeah.
So again, would it be a case of somebody coming in to see you, having the test, and seeing what they're susceptible to?
And of course, the food connection, it's a big one, because this is what we use to modulate our immune system. It's food. So sometimes it takes a very big dramatic change of diet. Sometimes it doesn't really matter what kind of change you make. Maybe you go into vegan diet, maybe you go into omnivore diet from vegan, and then everything changes absolutely. Yeah.
Exactly. And with all of the sort of tests that you're doing as well, do your clients have to come back and repeat those on a regular basis, just so that you have that baseline that you can sort of monitor them through?
Ideally, yes. This is how I would like to work, because I want to see if we're doing something, some kind of strategy, I want to see if it's working or not. Of course.
Exactly. And it's nice for the peace of mind of the client as well, to see that they're improving or not improving. Is there another question somewhere? I think no more questions. Oh yes, please ask a question.
About things.
Oh great. Well, you've got the right guy for you here.
I'm curious. So I just wanted to clarify what you were saying earlier. If you have a varicose vein, is there then no point in having sclerotherapy until you've resolved the varicose vein itself?
So yeah, absolutely. So having a varicose vein is a bit like sort of saying I've got a spot, and then not knowing if it's infective or anything else. So if you have a varicose vein, a bulging vein, we're talking about legs, or we didn't get on to talk about pelvic, because the pelvic varicose veins is the biggest thing that's changing now, because there's this strange thing where people think of varicose veins only being up to the thigh and forget you've got venous system up to the heart. And if you're a boy and you get varicose veins around your testicle, everyone says, you know, that's a varicocele. If you're a lady and you've got a varicose vein around your ovary and you've got pelvic congestion syndrome, you're told there's nothing wrong with you and you should see a psychiatrist, or you've got endometriosis. And it's estimated there's a million ladies in the UK who have got pelvic congestion syndrome, varicose veins around their pelvis. So when we talk about varicose veins, it's really any bulging vein beneath the umbilicus. So if you've got a bulging vein that is not just a one because you're hot and whatever, it is not the problem. It is the sign that there is a problem, and you should never have it treated without an ultrasound, because you're not going to get the right treatment. And there's only 3 reasons you get varicose veins back again after treatment. Everyone says they always come back. And the reasons are, the first one, in the commonest in the UK, is that the doctors either do their own scan or no scan, and you have the wrong treatment completely. You have the wrong veins treated, and you've got a 100% chance of getting your veins back. The second commonest is you get the right veins treated, but with the wrong technique, like sclerotherapy when it's too big, or laser not enough power, and that's about 30% per year. And if you can get rid of both of those, then the third one is only getting new reflux, which is only 3% per year. And our clinic's got down to 3% per year, and we're the only clinic in the world who've done that, because we've got rid of those other 2 causes. But it's just incredible that people always look at something and think that's the problem, without realising that's the sign of the problem.
That's interesting what you said about reoccurrence, because I was told that for a woman, there was no point having a varicose vein removed until you get pregnant, say, because you're likely going to develop them in pregnancy, or they'll come back in pregnancy.
20 years out of date.
So
20 years out of date. So research from 1999 showed very, very clearly, there's a brilliant study done by Linda de Cossard from the Cancer Chest Hospital. And what they did is they looked at people going through IVF. So all these ladies, they knew exactly the day that they got pregnant. And they scanned all their legs, and they put the scans away, and then they watched people go through pregnancy, and at the other end of pregnancy, everybody said, oh my gosh, look, I've got varicose veins because of pregnancy. Already had them beforehand, they just didn't see them. And it's the fact you go from 5 litres to 7 litres of blood, and it's got to go somewhere, so they become visible. If you look at the number of people who've got varicose veins by the age, there's no increase in women in childbearing years over men. So it just is that during pregnancy they become prominent. So if you tell women to wait until they've had their children, why they used to do it is nobody wanted you to go up the system. The NHS didn't want to do it, health insurance didn't want to pay for it. So it's a good way, and they knew they couldn't cure you in any case. Now we can cure it. We know that if we treat you beforehand, we're going to stop you getting thrombophlebitis of pregnancy, DVTs. You're going to actually have a much nicer pregnancy, and so you should have them treated. And you can't reopen veins that have been closed properly. So everything changed really in 1999. That's when lots of big studies came out. And the advice now is get your veins treated before pregnancy, so you don't have problems during your pregnancy. But to do that, you must have them treated correctly, because if you have the stripping or the half-hearted attempts, you're not going to actually get any benefit.
Follow-up thread question, vein question. Does the same advice apply to thread veins as with varicose veins for the legs?
The thread veins are really, really, really difficult, because the trouble with thread veins is they are, again, it's a symptom, it's a sign, and there are many causes of it. So when I was young, what most doctors will still tell you is if you've got lots of lots of blue veins down the bottom, you must have had the DVT in the past. That's they all say it, and there's nothing you can do. Absolute rubbish. It's you've got hidden varicose veins, and it's almost always curable. But you can get all sorts of other ones. We know that 11% of women get thread veins in the legs just because they've got that skin type. So there's no hard and fast rules with thread veins, because you can get them for different reasons, and different areas of the leg have got different roots on the venous side. Like a lot of people, you always think of veins, varicose being draining, so they're going to be at the bottom. Whereas if you look, a lot of ladies have thread veins on the thigh, and if you look with an ultrasound, they come from the knee, so they're actually draining upwards, so it's exactly the wrong way. So we don't fully understand thread veins. What I'd say is the principles are very, very clear though. You must treat any underlying reflux before you treat the veins, and you treat the veins with sclerotherapy. If you do that, you get the best long-term results without the problems of things like telangiectatic matting. So you will see some people have gone to clinics, aesthetic clinics, and not had the scan. They'll have sclerotherapy done on thread veins and they'll end up with this great big, looks like a horrendous birthmark. There's nothing you can do about it. It's called telangiectatic matting, and they used to say that it was an adverse reaction, it was an allergy. It's actually been shown that every single one of those patients who gets that has got an untreated varicose vein underneath that should have been treated first. So something about the pressure and flow, when you've softened it with the sclerotherapy and the healing process, causes that. So it's not just that it won't work, you've got this horrendous problem in, luckily, very few people, but it can come. So as long as you follow the principles, it's the right way. It's
So
just
still to get the proper scan first.
always, yes. I mean,
Every type of vein.
you should never ever have vein treatments on anything below your heart without a proper duplex scan, or else it's just guesswork.
Can we go back to the pelvic vein congestion syndrome? Is that what it's called?
Yeah, so it's officially called pelvic congestion syndrome, although I sit on the international committee for doing this. We've done all the original research in my clinic, and it's now, for America, it's going to be called pelvic venous disorders, because they think that pelvic congestion syndrome has got a bad name, so you might hear either of the two terms.
And what's the treatment for that?
So the treatment of it is, first of all, find it. So the last thing you want to do is have a gynecologist get hold of you, put you through an MRI machine or CT when you're lying flat, because when you lie flat you can't see varicose veins, they're empty. So no, you can't see them, or then have a laparoscopy where they go in and look round, and you can't see the veins because they're the other side of the omentum, the peritoneum. Or if you're slim enough and you can see the veins, they often see them but say, well, everyone's got big veins. So the gold standard test is one that we invented in 2000, and it's called the transvaginal duplex ultrasound, and it's by the Holdstock-Harrison protocol. And Judy Holdstock and Sherman Harrison invented it in our unit in 2000. It's now become worldwide known. And you lie at 45 degrees, so you actually get the reflux. Do a transvaginal.
So is that because then gravity sort of pulls the blood and makes it more visible?
Exactly the same way. So if you've got leg varicose veins and you lie flat, you don't see them.
Yeah.
So you know, a medical student would fail their finals if they were asked to examine varicose veins and they lay the patient flat.
And they didn't tip you upside down. Wow.
And there are ridiculous. There's a doctor struck off recently in London that I was involved in the case about 2 years ago, who was scanning his patients lying down for varicose veins and then saying, oh, I think this one's bad. You can't see varicose veins if you're lying down.
Absolutely.
So it's easy with legs because you stand the patient up. But if you want to do pelvic ones, you have to lie them at 45 degrees. Then when they're breathing, you can see the blood falling down if the valves aren't working. And that tells you you've got pelvic congestion. So you don't need all the expensive invasive tests. So at the moment what's happening is ladies who were just publishing a paper in a big journal in America where it showed them with satisfied people having had the treatment, which is pelvic embolization, are people who've had pelvic congestion misdiagnosed for 9 years or more.
Oh God,
Which
that must lead to all sorts of issues.
Unbelievably bad. Whereas in fact, what happens is ladies go to GPs, gynecologists, another good gynecologist, have all the tests, get told there's nothing wrong with them, and eventually find out after years and years. Whereas if you actually look at the cost and you look at the also the invasiveness of the test, if they had the ultrasound first,
yeah, exactly.
it would actually exclude the people out. So I mean, it is incredible. I've written a small book on it, and honestly, it just gets very frustrating because it is such a huge problem. And we went to the Houses of Commons on the all-party women's health, cross-party women's health issues, and we were totally and utterly shouted down by endometriosis groups.
Really?
Because everyone knows endometriosis, but nobody knows pelvic congestion.
But it's such a new field of vascular treatment.
And it's a third of all ladies who've got pelvic pain or discomfort at all.
Wow.
A third.
Does anything exacerbate it? Sort of like childbirth or
Yeah,
weight or hormone change?
We don't know enough about it to know for sure. What we know is it's one of the commonest causes of what's called deep dyspareunia, so discomfort on sexual intercourse, but deep inside, either before or afterwards. It's also a major cause of irritable bowel syndrome. It's also a major cause of the people who think they've got interstitial cystitis or things. It's also, we've recently published 2 patients who were told they need to have hip replacements because they had such painful hips. And when we fixed their veins for leg varicose veins, the hip pain disappeared. Low back pain is common. So if you imagine the weight and pain you get in your legs and you've got big varicose veins, transfer that to the pelvis and you can see how all of these same symptoms come.
Yeah.
Now the trouble is not everybody with those symptoms have got those. So a lot of people with irritable bowel or bladder problems or hip problems have other things. But it's just awful when something that's curable it's just varicose veins of the pelvis, basically.
Yeah, but you
isn't
need to see the
diagnosed.
expert, don't you? Because otherwise it's just going to go undiagnosed for such a long time.
At this moment, the hardest thing is actually finding a doctor who even recognises it, because one thing is we've got 2 gynecologists in England so far, and one's only a registrar who even recognise it, that we've found so far. It's really difficult to get anyone to diagnose it.
Well, if Olga gets anyone complaining of digestive issues and she does her stool test and can't find any microbiome issues, then I guess they'll be coming to you next.
I was just thinking, I've got a lot of patients I think need to go away.
Yeah, I think so.
And staff, I think.
Were there any more questions from the audience? If not, our amazing speakers will be here, so if you did have anything else you wanted to ask them, I'm sure they won't mind answering a few questions. A big thank you to our panellists. They've been amazing tonight. Super knowledgeable. Most of your answers went straight over my head, I'm not going to lie, but thank you for being so clear with everyone else. And thank you to everyone in our audience. It's been amazing to have you with us, as always. Please come to all of our events going forwards. I think we've got several lined up for April and May now, so you'll get information on those soon. Leave your details if you want any connections. Don't forget your goodie bag in the cloakroom. And yeah, good night. Thank you. Bye.